Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 503 of our pharmacotherapy series, which majors in anemias. The next case reads, ADH is a malnourished appearing woman in her second trimester of pregnancy, who presents to the local health clinic for her regular checkup. She is a multiparous, 26-year-old woman with a 7-year history of excessive alcohol intake and has been using cocaine frequently for 3 years. She lives with her boyfriend and her 19-month-old daughter. During both pregnancies, ADH lost 8 to 10 pounds during the first trimester, secondary to nausea, vomiting, and anorexia. Her only complaints are dyspnea on exertion, palpitations, and diarrhea. Pertinent laboratory values include the following: a hematocrit of 25.5%, an MCV of 112 femtoliters, an MCH of 34 picograms per cell, RBC of 1.1 times 10 power 6 per microliter, iron of 179 micrograms per deciliter, Phe of 40 nanograms per milliliter, serum vitamin B12, 350 picograms per milliliter. The normal range is 200 to 1000 picograms per milliliter. Reticulocytes of 1%, platelets of 70,000 per microliter, WBC count, 2000 per microliter with hypersegmented polymorphonuclear neutrophils, abbreviated as PMN. Lactate dehydrogenase of 425 units per liter, bilirubin of 1.2 mg per deciliter. ADH is not taking any prescription medications. So my question to you reads, what factors make ADH at risk for folate deficiency? As with most patients who are folate deficient, ADH has more than one risk factor. Cocaine and alcohol, together with multiparity complicated by anorexia, nausea, and vomiting, could lead to poor nutrition. Alcohol has toxic effects on the intestinal mucosa and interferes with folate utilization by the bone marrow. ADH should be asked specifically about her dietary habits and recent weight history. She may have a folate-poor diet for financial reasons or because she is overcooking her food. Alternatively, cocaine may be causing anorexia. The nutritional intake of people who abuse alcohol and drugs is often poor. The diagnosis of folate deficiency is plausible, considering folate deficiency can develop in a matter of weeks to months. My next question to you reads, which laboratory values support the diagnosis of folate deficiency? How should ADH be treated and monitored? ADH's laboratory values reflect macrocytic anemia, that is a hematocrit of 25.5%, an MCV of 112 femtoliters, with pancytopenia, that is a reduced number of RBCs, WBCs, and platelets. Serum vitamin B12 concentrations reflect normal vitamin B12 stores, but folate stores are inadequate as exemplified by the low RBC folate concentration, pancytopenia, and macrocytic anemia. Serum folate concentrations generally reflect folate balance during the past 3 weeks, although one balanced meal can raise serum levels and falsely elevate body stores. Tissue folate stores are more accurately reflected by the RBC polyglutamated folate content, which is approximately 10 to 30 times the corresponding serum folate concentrations. Hemolysis or vitamin B12 deficiency causes leakage of monoglutamated folates from cells, thereby falsely elevating serum folate levels. ADH should be counseled regarding her nutritional and social habits. Because the estimated total body folate store is only about 5 to 10 milligrams, 1 milligram of folic acid given daily for 2 to 3 weeks should be more than adequate to replace her storage pool of folate. Higher dosages, up to 5 milligrams, may be needed, however, if absorption is compromised by alcohol or other factors. Once stores are replenished, ADH should continue folate supplements throughout her pregnancy and lactation period. She should be reassessed after the course of therapy to determine response to therapy and whether the cause of the folate deficiency has been corrected. Supplementation with folic acid 1 mg per day may be required as long as risk factors are present. ADH's fetus is unlikely to develop folate deficiency because maternal folate is preferentially delivered to the fetus. However, sustained folate deficiency during pregnancy can cause birth defects in the newborns. ADH's response to therapy can be monitored by several different parameters. Although bone marrow aspirates are not obtained routinely, the RBC morphology should begin to revert back to normal within 24 to 48 hours after therapy is initiated, and hypersegmented neutrophils should disappear in the periphery in about 1 week. Serum chemistry and hemogram studies should begin to normalize within 10 days. The reticulocyte count should increase by day 2 to 3 and peak by day 10. Bilirubin and lactate dehydrogenase values should normalize in 1 to 3 weeks. Finally, the anemia should be corrected in 1 to 2 months. Once anemia is corrected, 100 micrograms daily of folate as a nutritional supplement should be adequate for maintenance treatment, independent of the patient's pregnancy or lactation status. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom, and if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 504.